Hello, I'm Peter Rowland, and I'm going to talk today about imaging for cochlear implantation. We will cover 4 general topics in this talk: the importance of a collaborative radiologist, advantages and disadvantages of CT and MRI, why imaging is used routinely in evaluating cochlear implant candidates preoperatively, and the utility of imaging in assessing cochlear implant recipients postoperatively. To start with, I want to emphasize that to derive maximum benefit from imaging, clinicians should work closely with an experienced radiologist. A radiologist with a specific interest in temporal bone imaging and cochlear implantation will understand the clinician's needs. For example, they will recognize that contrast is not needed for either MR or CT scanning, and that reconstructive sagittal imaging is an essential part when evaluating a potential cochlear implant recipient. Moreover, a variety of hardware is available from different manufacturers. Different hardware will use different imaging protocols, and an experienced radiologist can determine which protocols and sequences are best based on the clinician's needs and the equipment available. For example, if available, cone beam imaging can be especially helpful in identifying electrode position within the cochlea because it more effectively suppresses artifact from the metal electrode contacts. Equipment and protocols change rapidly, and a radiologist committed to temporal bone radiology will always be aware of the latest developments. An experienced radiologist can provide very expert and subtle interpretations. Minimal obstruction of the cochlear duct, subtle modular defects, and changes in the cochlear aperture, for example, will not be overlooked. An experienced radiologist will guide technicians to make sure the appropriate sequences are obtained. This is important because the imaging sequences needed to evaluate cochlear implant candidates are different from those generally utilized in brain imaging. Some centers use primarily MRI for evaluating cochlear implant candidates. Other centers use primarily CT, and some centers routinely use both. Individual centers should work out with their radiologist which techniques to utilize. And finally, some experienced temporal bone radiologists are willing to perform an MRI in an implanted patient without removing the magnet from the stimulator receiver. Med-El devices are currently FDA approved for 1.5 Tesla MRI scans without magnet removal, but the other available devices are not. With careful binding of the stimulator receiver, some centers now perform MRI scans in implanted patients with the magnet in place, even for those devices for which it is not FDA approved. The magnet will obscure a portion of the brain and skull within 2 to 4 centimeters of the implanted device, but useful images can be obtained from most of the brain and all of the rest of the body. MRI without magnet removal may be safe, at least in 1.5 Tesla machines, and is certainly less expensive than magnet removal. These MR images show minimal obstruction of the basal portion of the basal turn of the cochlea, a subtle finding. This image was obtained from a child with a right cochlear implant. The magnet was left in place. Artifact obscures most of the ipsilateral temporal bone, but the majority of the brain can be accurately assessed. Now let us review the relative advantages of MR and CT, and briefly review the circumstances in which each is most appropriate. The most common modality used to evaluate cochlear implant candidates and recipients is high-resolution, fine-cut temporal bone computed tomography. No contrast is necessary. Its advantages include its widespread availability and relatively low cost. CT scanning can be performed very quickly. Once an individual is within the scanner, acquisition of images takes only a few minutes. CT scanning provides excellent bony detail and is especially useful when evaluating the middle ear and mastoid. It can determine the position and patency of the round and oval windows, catalog the anatomic changes associated with congenital syndromes, and identify the signs and symptoms of both acute and chronic infectious processes. CT scanning is clearly the imaging modality of choice when detailed anatomy of the facial nerve is needed. This can be especially important in individuals with craniofacial syndromes, with any cochlear dysplasia less differentiated than intracochlear partitioning defect type 2, that's the classic Mundini defect, and anatomic anomalies of the vestibular system. CT is the accepted modality for imaging implant recipients. In this image, a CT scan readily identifies the stenotic cochlear aperture on the left. The cochlear nerve, if it's present, probably does not pass into the medialis. The radiation exposure associated with CT scanning is considered a disadvantage. This has become an issue of particular concern in children. Importantly, CT scan cannot verify the presence of cochlear nerves, an important consideration in individuals with profound hearing loss. When magnetic resonance imaging is performed to assess cochlear implant candidacy, heavily T2-weighted images are the most useful. The principal advantage of MRI is excellent soft tissue resolution. MRI can directly ascertain the presence of cochlear nerves and is more sensitive to intracochlear anomalies. It is also most sensitive to endocochlear duct obstruction because the absence of fluid signal can detect fibrous or soft tissue ductal obstruction. This set of images demonstrates complete fibrous obstruction of the cochleae bilaterally on MRI, but it's not visible on CT scanning. Both cochleae appear normal on the CT images, but are absent on MRI as a consequence of the fibrous obstruction. Finally, no radiation exposure is associated with MRI scanning, and there are no accepted adverse effects of an MRI scan. MRI has two principal disadvantages. It is usually more expensive, and it takes longer. The longer scanning time generally necessitates the use of heavy sedation or general anesthesia in young children. This further increases the expense and is associated with some risk, albeit small. Routine MRI scanning of young children is most easily and safely accomplished in a center that performs it frequently. Why do almost all cochlear implant centers routinely image potential cochlear implant recipients? Imaging is used to determine if contraindications to the implant procedure are present, to select the best device for a particular patient, to help select the ear that should be implanted, and to clarify the individual candidate's unique surgical anatomy. Anatomically, a cochlear implant is possible if and only if the potential recipient has a cochlea, an auditory nerve, and an intact central auditory system. Both CT and MRI can be utilized to identify the absence of a cochlea. A small internal auditory canal on CT scanning suggests the absence of a cochlear nerve, but only MRI scanning can verify directly that an intact auditory nerve is present. Individuals with no response audiograms, or individuals who respond only to low-frequency stimulations at high thresholds, responses that could be vibrotactile, need direct confirmation that the cochlear nerve is present. While MRI scanning cannot determine whether the central auditory pathways are functioning normally, it can detect disruptions of the central auditory pathways from stroke, trauma, tumor, and other types of central nervous system pathology. This image is a sagittal reconstruction at right angles to the internal auditory canal. A normal facial, vestibular, and cochlear nerve can be seen on the right. However, the cochlear nerve is conspicuously absent on the left. In this image, the cochlea is entirely absent, and the vestibule is cystic. If no contraindications to cochlear implantation are present, image is often utilized to identify anatomic details that would affect device selection. The size and morphology of the cochlea can help determine which electrode is best suited for an individual cochlear implant candidate. Some surgeons would select a shorter electrode for a shorter cochlear duct. Shorter electrodes are sometimes selected for individuals with severely dysplastic cochleae, for example in common cavity or hypoplastic cochleae. Some surgeons would choose one of the electrodes especially designed for a common cavity deformity when a common cavity is present. A very common purpose for preoperative imaging is to detect obstruction of the cochlear duct. CT scanning can detect ossification of the cochlea from labyrinthitis ossificans, otosclerosis, or primary diseases of bone. MRI can detect soft tissue obstruction of the cochlear duct because it is sensitive to the fluid signal within the cochlear scali, and absence of this signal will indicate the cochlear duct is obstructed. Imaging is also used to identify anatomic conditions that would make the surgical procedure more complicated, or which would favor changes in the surgical approach or the ear selected for implantation. While not always essential, it is useful to know in advance if performing the cochleostomy is likely to be accompanied by a CSF gusher. Advanced knowledge will allow the surgeon to discuss this possibility and its management with the potential recipient. If the surgeon uses particular materials or special techniques in managing a gusher, these can be available in advance. Gushers occur more commonly in individuals with cochlear dysplasias, in subjects with modular defects, and with dilated vestibular systems. The risk of a gusher is also increased in individuals with enlarged endolymphatic sacs or enlarged vestibular aqueducts. A shorter electrode array may be most appropriate for this hypoplastic cochlea. Note that the vestibule is dilated, increasing the likelihood of a gusher and a facial nerve anomaly. This image shows cochlear partitioning defect type 2, the classic Mondini deformity, and is associated with a large endolymphatic sac and duct, incomplete partitioning of the apical portion of the cochlea, and it too presents an increased risk of CSF gusher. The upper image illustrates a single sac deformity. The lower image demonstrates incomplete partitioning defect type 1. The cochlea and vestibule are saccular. Both may best be managed with a shorter electrode, and subsurgeons would prefer banded electrode contacts. Both deformities are associated with an increased risk of gusher. Abnormal or unusual middle ear and mastoid anatomy rarely preclude cochlear implantation, but such variations can increase the complexity and the difficulty of the surgical procedure. While assessment of the anatomical details of the middle ear and mastoid is best accomplished with CT, MRI usually provides an indication that a variation is present. Programs that use MRI as their principal screening tool, based on these hints, can then get a CT scan to clearly define the anatomic variation. The upper image shows the ground glass appearance associated with Paget's disease. The lower image shows a congenital cholesteatoma unsuspected prior to imaging. If the opposite sides were normal, then they should be chosen for the implantation. This image comes from an individual with Down syndrome. He has a dysplastic vestibule on the right. The bony island of the lateral semicircular canal is small, which suggests the possibility of an anomalous facial nerve. CT scanning should be considered. A small contracted mastoid with low-lying dura may limit access to the facial recess, and operating in this small contracted space increases the risk of violation of the external auditory canal, damage to the sigmoid sinus, and of the posterior fossa or middle fossa dural injury. Dural injuries can result in a cerebrospinal fluid leak. Children with syndromic conditions like charge or Goldenhars can have very anomalous middle ear and mastoid anatomy and may present a daunting surgical challenge. The middle ear space may be very contracted, the round and or the oval window absent, and the ossicular chain malformed. In children with charge, there are often associated malformations of the cochlear and vestibular system. Almost all children with charge have absent semicircular canals. Venous lakes may occupy the mastoid, and atresia of the external auditory canal may also be present. This is a series of images from a patient with charge. The vestibule is small. There are no semicircular canals. The oval window is atretic, and the facial nerve is abnormal. Injury to the facial nerve is an especially feared complication of cochlear implantation. Candidates with syndromic conditions, dysplastic cochlea, and anomalies of the vestibular system like dilated vestibules and absent semicircular canals are especially vulnerable. Preoperative understanding of the precise anatomy of an anomalous facial nerve helps prevent injury. Facial nerve anatomy is best assessed using CT. Both CT and MRI can detect a high jugular bulb or very anteriorly placed sigmoid sinus, but CT is better for detecting a dehiscent jugular bulb. Other venous anomalies that can be detected on preoperative imaging are a very large mastoid emissary vein or the large venous lakes in the mastoid cavities of some individuals with CHARGE syndrome. If the jugular bulb is very high and very anterior, as is sometimes the case if the lateral semicircular canal is absent, the facial recess may become inaccessible from a transmastoid approach, and the electrode may need to be inserted after entering the middle ear via a tympanomeatal flap. Imaging can detect abnormal arterial anatomy, most particularly an aberrant internal carotid artery. The aberrant internal carotid artery is really an absent internal carotid artery, which is replaced by a very enlarged descending pharyngeal artery that runs through the middle ear space. A very large stapedial artery can also be detected on preoperative imaging. While MR and CT scan can both suggest the presence of altered arterial anatomy, suspected anomalies should be verified on MRA or with formal arteriography. This slide is from a patient with Goldenhar syndrome. There is external auditory canal atresia, a massively enlarged stapedial artery, and an anomalous facial nerve. The oval window niche is absent. And finally, imaging is often utilized for the postoperative assessment of cochlear implant recipients. Sophisticated techniques are now becoming available to allow one to determine whether or not the electrode is within scala vestibuli or scala tympani. A cutting-edge use of postoperative imaging is to determine the exact location of individual electrodes within the intracochlear scalae. Precise electrode location can be used to improve programming of the electrode array. A more common use of postoperative imaging, almost always CT, is determining whether or not the electrode is within the cochlea. Sometimes an electrode is misplaced at the time of the implantation procedure. This is readily identified on imaging. Plain films can be used intraoperatively to verify the correct placement of a cochlear implant electrode array. Plain films or CT can be used postoperatively to determine whether the electrode array is in the cochlea, middle ear, or internal auditory canal, which can happen in some dysplastic cochlea. Occasionally, an electrode will back out of the cochlea, sometimes long after the implant procedure. If changes in the recipient's map suggest that the electrode has moved, CT scanning can determine how much of the electrode remains within the cochlea. These four images show that the electrode array has coiled up in the vestibule and is not within the cochlea. The electrode in this image is extracochlea. It has passed below the cochlea into the hypotympanic air cells. Both plain films and CT can be utilized to determine whether the stimulator receiver has been displaced or has migrated. Imaging can also determine displacement of the magnet from the stimulator receiver. And finally, imaging can be used to identify postoperative complications, otitis media, mastoiditis, or postoperative hematoma and seroma. I do hope that you have found this brief introduction to imaging useful. You are now ready to move on to the next module.